Laboratory Values for Iowa Lakes Community College, Introduction to Nursing Concepts. This is Martha Olson. This will be part 1. We learn lab values because they tell us about important health things for our patient and give us kind of key information. It helps a physician make a diagnosis and correct the underlying problem, and we also need to understand the importance of lab values because many of them are very serious and need to be reported immediately. To memorize and to learn them, note cards where you're flipping through and thinking of them constantly, but also think about how they relate to the patients that you're caring for. Case studies. What would be a serious type of lab value that we would want to look at for a certain type of patient in a scenario. Somebody with a hemorrhage, you're going to look at your hemoglobin and hematocrit. Somebody with diarrhea, we need to look at electrolytes. You're diabetic, we need to look at their fasting blood sugar. So as we look at scenarios and think about how we're going to apply them, challenge yourself to put lab values as part of your nursing interventions for helping to treat that patient. Our first set is looking at oxygenation. Our red blood cells, male and female, have different values. Kind of just learn generalized ballpark numbers to help you as you're getting started learning these. Your red blood cells carry oxygen out to the tissues. Without enough red blood cells, you're going to be pale, you're not going to have the oxygen getting to the tissues, and you might see a delayed capillary refill. A person's going to be very tired. You can even have a person that has chest pain because the myocardium is not getting enough oxygen carried to it from the red blood cells. Hemoglobin and hematocrit are often called an H&H. We always do them pre-surgically to make sure a patient is going to be able to carry oxygen to the tissues. We wouldn't want to stress somebody during surgery and with any blood loss if their hemoglobin and hematocrit are not at adequate levels. Again, the male levels are just a little higher. Females, because of menstrual blood loss, tend to have just a little lower hemoglobin until after menopause. As we look at your patient with congestive heart failure, we're going to look at a blood level called a BNP. Your person with congestive heart failure is not able to pump enough blood to meet the metabolic needs of the person, and it's typically because they have too much fluid on board. They will come into your ER very short of breath. We call that dyspnea. They have to sit upright to be able to breathe, and they might really have that deer in headlights look because they are feeling very stressed without getting enough oxygen to breathe. The position where they're sitting upright is called the orthopnea position, and you will also notice a change in vital signs where they have tachycardia, tachypnea, breathing fast, or heart rates going fast. And with all of this fluid, you might notice in your assessment jugular vein distension. That tells you there's a lot of fluid on board and it's not able to get out of the veins as quickly as it needs to. So your BNP is a level that should be 100 or less. I've seen patients come into the ER with a level of 800. What we do for them is we consider first of all the oxygenation status, get them on oxygen, get them sitting upright. Then we try to get some of that fluid off with a diuretic and follow up with getting weights and different things to make sure that we are looking at how much fluid is being removed. Typically these patients with CHF will be admitted for closer observation and treatment. Continuing with some of the oxygenation scenarios, we think about the post-surgical patient that has a hemoglobin of 8.2. Typically at 8, we start thinking about getting 2 units of blood to transfuse because they've had some blood loss. It depends on how the patient feels. Are they symptomatic? Are they having change in vitals? Are they dizzy, having chest pain? Those are indications that that hemoglobin is too low and we need to do something significant to help them. Your patient with a low hemoglobin and hematocrit will be very pale because there's no oxygen getting out to the tissues, or very little. They're tired, again, because of lack of oxygenation. They get very dizzy when they stand, so you have to be careful. And their heart rate oftentimes will be elevated as the body is trying to compensate. So your post-surgical patient, you call the physician and say, you know, the hemoglobin and hematocrit levels just came back. The hemoglobin is 8, and the physician typically will order a blood transfusion of a couple of units of packed red blood cells. Again, we check the labs after the blood is administered to see, did it improve? Has it helped the hemoglobin and hematocrit? If the patient is very serious, you may see that lab being drawn right after the second unit has been administered, or more commonly, if the patient is more stable, they will check the lab, the hemoglobin and hematocrit, in the morning with the regular blood draw. When we administer the blood, you might notice that your patient gets more pink, their O2 saturation is going to increase, and the patient feels better. They're not as dizzy, not as tired or lethargic feeling. Our infection control unit is looking at the white blood cells. Normal is 5,000 to 10,000, and this is also called leukocytes. Leuko is the medical term for white. White blood cells help us fight infection, and when we look at infection control, we want to be able to break down what we call the differential, and that is all of the 5 different types of cells that the body has. That number should come to 100 because it's a 100%. So we look at, are the neutrophils increasing? What's going on with the other ones? What's going on in the body? And what we know is neutrophils are typically the first cells that come to the site of action. When a person has an infection, the neutrophils are very speedy at getting there, and they fight the good fight, but they don't have a very long ability to fight. And so when the neutrophils are elevating, we know that that infection is on the rise and it's getting worse. Lymphocytes come second with the differential. Those help more with chronic bacterial and acute viral infections. Monocytes come right after the neutrophils. Monocytes are a little slower, they're bigger, but when they come and help fight that acute bacterial infection, they can stay longer. They have a longer lifespan than the neutrophils. So the neutrophils show up first and fight, but they get tired pretty quickly, and the monocytes come in a little slower, but they hang with it a little longer to help fight that infection long term. The last component of our differential is the eosinophils, which look at parasitic infections, and then our basophils tend to have more to do with some of our allergy type of things. So as we look at an increased white blood cell, it might be talked about or called a leukocytosis, and besides infection, it can also help indicate some inflammation, tissue necrosis, or even like a leukemia. And so we need to kind of evaluate what else is going on within the body that might be causing the leukocytosis. A patient comes into the ER with pain. We see the neutrophil is elevating, and we know that an infection within that body is getting worse. Your patient might have what we call a hot appy or an appendicitis. ITIS is your suffix on the end of that word that means infection. We take them into surgery. We remove that appendix, or we do an appendectomy. TOMY on the end of a word, or the suffix on that word, is to remove. When we get that appendix out, we hope, if it hasn't ruptured, that the white blood cell count will very soon post-surgically go back to normal. The opposite problem is your patient on chemotherapy. The white blood cells are made in the bone marrow, and many of your chemo radiation can decrease the amount of white blood cells that bone marrow is able to make. And so your patient on chemo is going to be very immunocompromised or very vulnerable to getting an infection, because a normal white blood cell is 5,000, but they may only have 2,000. And so we take special precautions with that patient on neutropenic precautions. We gown and mask when we go into the room to protect them from us. We use PPE or personal protective equipment in a way that keeps us from getting that person sick because of how vulnerable they are. We also do not take fresh flowers or fresh fruit in that room, because they could also cause infection. We also look at bleeding or our coagulation studies for our surgical patient. We look at them for a number of long-term health disorders like hemophilia. Many of your patients are going to be on Coumadin, which is an anticoagulation medication that many patients take when they have heart or stroke issues. So our prothrombin time, or PT, is 11 to 12.5 seconds. INR is called International Normalization Ratio, and it's a lab value that they standardize so that every lab comes up with kind of the same number. Your PTT is partial thromboplastin time, and that is also done in seconds, 60 to 70 seconds, and that one goes with heparin. And then our platelets, which help with clotting, 150,000 to 400,000. When we look at the PT or pro time, it helps us with that extrinsic clotting system, and it measures factors 1, 2, 5, 8, and 10. When we look at somebody that possibly has cirrhosis of the liver because of alcohol or gallbladder problems, that can interfere with clotting because these clotting factors are made in the liver, and if the liver is not healthy, they can bleed to death very quickly. We also know that patients taking warfarin or Coumadin to slow that clotting down because they've possibly had a stroke or a DVT, deep vein thrombosis, heart valve replacement surgery. Those are patients that are on these anticoagulants, and we measure how well that medication is working by drawing a PT with that. When we look at the INR, again, our results are independent of the reagents or methods used, so that's a number that when I worked in the clinic, we would get an INR. The doctor would look at that and make determinations on medication dosages if it needed to be changed for your patient on Coumadin. Your PTT goes with heparin. This is for the intrinsic system, and we know that it looks at different factors from the PT, and your patient with hemophilia will have prolonged PTT times. Heparin is often given IV for patients that are having some issues with clotting, and we have to watch that very closely because too much heparin could actually cause a patient to hemorrhage for us. The platelets are the last part of that, and our normal is 150 to 400,000, and that is the cells that go to where a person is hemorrhaging and they kind of clot off, or like put your finger in the dike to keep the thing from leaking kind of effect. Platelets clump together and they kind of make a clot so that the area that is hemorrhaging or having leaking of blood can then be clotted off. Low count is thrombocytopenia. Penia as a suffix means smaller, and high counts of platelets are called thrombocytosis. So your patient on Coumadin, we would want to definitely teach them to be watching for bleeding. That might indicate that their warfarin dose is too high. Perhaps they bruise easily. You take a blood pressure and the blood pressure cuff leaves bruises after you take it off. We would also think about not allowing them to use a straight blade to shave, because if they would nick their skin, they're going to bleed a lot. Your patient with a deep vein thrombosis or blood clot might be ordered heparin IV. That usually comes as a pre-mixed bag, as you can see on the right side. And as we look at our heparin, it comes in that standardized dose so that when we use the nomogram, we can calculate the units per milliliter fairly easily. Like I said, you'll definitely want to double check your math and your IV pump with another nurse because of the high-risk nature of administering heparin. We follow the protocol of the facility. A nomogram is kind of like the recipe that the doctor leaves for what you do. You get a PTT level back, excuse me, and the lab values then will tell you what you do with that.